the first time, thank you for joining us. Just want to remind everyone that we're going to be utilizing the Q&A feature that's at the bottom of the screen. That's the main place to ask questions. If you're having an issue with that, there is a chat box as well, but the Q&A is ideal. We also have our email that's available, not only during this lecture, but as well, it's constantly available if anyone has any questions on an ongoing basis. The medical question hotline is medicalhalachaquestions@gmail.com. It's very important that we have sponsors for this because there are costs that are involved, and we really, really appreciate people that step up and allow us to have this share. We already have 100 people, Baruch Hashem, on the lecture for tonight. Tonight's share is sponsored by Edelman Health, which is a practice providing concierge home visits in Muncie for elderly and medically complex patients, as well as hospital at-home services for those who need IV antibiotics, LASIK, steroids, fluids, and frequent labs. The phone number for Edelman Health is 347-741-7582. Once again, tremendously helpful that they sponsor tonight, and we recommend patronizing their business if that could be of help to you. We also would like to thank Born Creative, which is a branding and graphic design studio, and they've been very involved in making sure that they help us publicize the various shiurim that we're trying to put together. As you know, you sign up for tonight. Tonight is a Shabbos lecture. We hope to continue doing various shiurim that are relevant, whether Linyan Shabbos, as the different Yom Tovim come up as well. I want to once again thank Rav Asher Millman for joining us. He's the Rav of Kahal Shari Avram in Passaic, New Jersey. He's the rabbinic advisor for Hatzalah Passaic Clifton, and he serves as well on the Machon Chaim Aruchim. He's affiliated with Hackensack University Medical Center and has a wealth of knowledge to share with us, both from a halachic vantage point as well as a native understanding of the medical underpinnings of the questions we're looking at. Anyone who's ever dabbled in Hilchos Shabbos, definitely with regards to health or any other aspect of Hilchos Shabbos, knows that it's complex. It's a massive yam. And this particularly, what we're dealing with tonight is complicated because you have to both have a medical knowledge as well as understand the various elements that come together from a halachic vantage point. And we're tremendously privileged to have Rav Millman with us. And without any further ado, I'm going to turn it over to him. Like I said, there is a Q&A box. Please feel free to utilize that as the share is going on. I'll be monitoring that, and we'll be pausing midway through to handle questions and anything that might not be handled tonight. We hope to continue it in the future components of the series. Enjoy the rest of the share.
Okay, thank you, Ramesha. I appreciate the introduction, and really a big thank you to everybody here as well. Most people on the Zoom tonight are involved in patient care, directly, indirectly, tangentially, but everybody here are those in Klal Yisrael who are the givers. They're making sure that others are always getting what they need, and it's a big Kiddush Hashem to see everybody here trying to increase their knowledge, to improve their capacity to do even more of their hishtadlos and more of their help for Klal Yisrael. So I want to give everyone here a big bracha, that everyone here should be zeicha with gesund, mazel, bracha, parnasa, and kol brechas Torah in this chus that you help so many others. Kind of like Ramesh mentioned, Tuesday night, 9:30, medical emergencies on Shabbos is kind of like putting out like a notification. We're going to climb Mount Everest tonight in the next hour. Like, come and join us. Obviously, to cover the medical halacha shailas that come up on Shabbos are extremely complex, and there's many different aspects and nuances and caveats, but we'll try to do our best to at least give the basic overview and the basic klalim of what major cases entail, and hopefully from then we can extrapolate and apply it to other cases as well. So let me just open up the PowerPoint and we'll go through it together. There'll be a few pauses in the shir where, Ramesh is going to, feed some of the questions that were asked, and we'll do the best we can with Sata Dishmaya to give the Olam something with Tachlis tonight. Okay, so before we even, begin the conversation of refuah on Shabbos, it is very important to always make sure that if you have a suffix and if you're not sure whether an appropriate intervention should be taken, you should not delay by going to seek out a Rav, and you should not do it in a fashion that is less than ideal. We are obligated, as it says, v'chai bahem, that we have to do whatever we can, and it should not be any delay or tarrying if you're not sure what to do. That is something that is entirely inappropriate, and we'll see in a moment how chamer, how egregious that is. Just even on the first slide, it reminds me of a case. I think it was 2 years ago in the winter, and there was a Hatzalah call on a Motzei Shabbos, and I was there, and we see a young child, maybe 3, maybe 4 years old, and the child is working. Real respiratory distress, accessory muscle use, belly breathing. This child is really working, and we see the parents like fiddling with a nebulizer, about to give the kid a treatment. So, of course, the first thing that you do, is ABCs, and we assist with that. We ask the patient's parents, like, what happened today? What were the events preceding, this episode of respiratory distress? And the parents tell us, well, we try to use the nebulizer with a timer to give our kid albuterol, as the child is a severe asthmatic, and the timer on Shabbos wasn't set appropriately. So we just skipped giving the child the nebulizing treatments over Shabbos. Like, shell shock to hear such a story. You're giving a kid who is a severe asthmatic, small airways, high risk for demise, and instead of doing what was appropriate, was to give the kid the nebulizer, they just did nothing because they were scared that the timer wasn't working and therefore they couldn't turn it on. Obviously, that's something that is extremely inappropriate and something that should never be done. Let's see inside just how egregious and how severe that is. The Shulchan Aruch brings an Orach Chaim in Shin Chav Ches, a halacha. Beis, Maramaka number 1. Misha yesh lo chaydi shel sakana. If somebody has a life-threatening or a potentially life-threatening illness, mitzvah lechala labas Shabbos. It is a mitzvah to desecrate Shabbos for that person. 1, it's a mitzvah. 2, if you are zariz, hazariz harei zeh meshubach. If you do this with zeal, with alacrity, you are praiseworthy. And if chas v'shalom the inverse is true, if you delay because you're not sure if it's mutter or it's aser, v'hashoyel harei zeh shoifech damim. You have the category of a murderer, somebody who spills blood. Says the Mishnah Berurah, why is it so bad? V'hashoyel, Maramaka number 2, perish oisa ha'eshu hu mischased. He thinks he's a chassid. V'yarei lechalo Shabbos b'chela kazeh. He does everything api arav. He does choshen mishpat api arav. He does his kashrus api arav. So he thinks, okay, when it comes to pikuch nefesh on Shabbos, I should also ask a rav. Says the Mishnah Berurah, explaining the Shulchan Aruch, harehu shoifech damim. He is equated and equivalent to a murderer. Sheba'oid shehu hoylech lishol yechla shachol leYoser v'yachol histakein. Varei akasav oimer loisamar adam reyecha. So first of all, it is very significant if one is going to delay doing any interventions, whether he's somebody who's asking a rav, or whether he's a provider, a doctor, a PA, an NP, a nurse, whoever it may be, or maybe if it's an askin who has to advocate on behalf of a patient. If there's a concern that it may be life-threatening or potentially life-threatening, do not delay to do the utmost for this patient. And if you do, you're qualified the Shulchan Aruch as a shoifech damim. And says the Mishnah Berurah weiter, it's not only the responsibility of the person, but the Rabbanim also have a responsibility. Uv'Yerushalmi Isa hanishal harei zeh meguna. The Rav who is asked is also meguna. He's also disgraced. Why? Because a Talmud Chacham b'mkaimai hayaloi lidroish. He should have told people l'chol kedei sheyedu kol ha'am v'lo yitzarech l'shoyaloi. So he's also responsible for not teaching people that they should not be asking in cases of safek or vadei pikuach nefesh. It reminds me of a story, a very unpleasant story, of a Hatzalah case and the parents of a child who went unresponsive, and this is a true verified story, and they didn't know what to do with an unresponsive child. They put the child in a stroller, and they walked the child, and this is without an exaggeration, without hyperbole, 20 minutes to the home of the Rav to ask the Rav, what should we do? So the first thing the Rav did is he called Hatzalah. The second thing he started doing is he started screaming at the parents, Reitzchem, 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 you're murderers for not calling Hatzalah right away. And the Rav was emulating this Shulchan Aruch. If you delay, you're Reitzeach. Now, I wasn't on scene, and I don't know if I would have done this, but in theory, maybe someone should have screamed back at the Rav and told him, Megune, Megune, you're also responsible because you didn't teach the Mispalim what they should do. And that's something that is very, very, very significant. But it's more than just being a Shefech Damim. The Rambam says in Hilchos Tshuva, in Perek Beis Halacha Gimel, Marmukah number 3, if somebody thinks that he shouldn't be Mechalel Shabbos for a Chayla, says the Rambam, Ve'elu hapi karsim. He's similar and akin to an apikairis, a heretic, a kaifer. She'oimim shezeh chilul Shabbos. So not only does one have a status of a murderer, he also has a status of an apikairis. And there's a well-known story from Reb Chaim Brisker, who was the father of the Litvische Yeshivische world, and he had a grandson who was sick on Shabbos in Brisk. And of course, they rang the doctor. In those days, the doctor probably came in a white coat, with that thing on the forehead with the metal circle, which actually is a medical tool. And the doctor is assessing the grandchild. And the doctor says that, I think it would be helpful if there was a little bit more light in the room. And one of Reb Chaim's sons was in the room as well. Not clear which one, different versions of the story. And the son hesitated to turn the light on. And Reb Chaim screamed at him. And he said, Apikairis, Apikairis. Now, I don't know if that's how we're mechanech our children today by calling them Apikarsim. But Reb Chaim was making a point that one who hesitates, besides the Shefech Damim, it's akin to heresy, because we're Mechalel Shabbos for Chaylim who need care of our intervention. And one more caveat before we really start the shir is the words of Rabbi Shlomo Zalman Auerbach in the Shulchan Shlomo in Marmukah number 4. Rabbi Shlomo Zalman says, let's say you thought somebody had an acute abdomen, and it was just a passing cramp, and you were Mechalel Shabbos, you drove for them, you did a million malachas for them, and you feel very bad. Maybe it's like ta'ab devar mitzvah. I made a mistake at a mitzvah, and I have to bring a carbon. I have to atone for this sin because the patient was really totally fine. Says the Shulchan Shlomo, says Rabbi Zalman Auerbach, mistavra, it's very mistaber that this is not ta'ab devar mitzvah, because you were doing what the Torah wanted, and therefore you have no responsibility at all. You're not on the hook. You're not chayiv bechlal, even though it didn't turn out to any type of sakana. So if you delay your shefech damim, if you don't educate people, which is incumbent upon the rabbanim, and many people perhaps in this chat, who may be doctors, PAs, nurses, NPs, whatever it may be, they have to tell people, don't ask this time, don't wait. And of course, you're also perhaps an apikairis if you delay as well. So this is just the severity and the seriousness that we have to treat the hilchos of refuah on Shabbos. Now let's get into really the kishkas, the ikr of where we are going to be discussing tonight. So in halacha on Shabbos, there are really 5 primary categories of ill or sick people that have different halachas. We'll go from the most severe to the most benign. The first category is a chayla vadai or a suffix sheyesh bo sakana. There is definite danger or potential danger, which is life-threatening. The second category is sakanas aver, where a limb or the functionality of a limb might be impaired. Now, it's important to point out, if somebody has a humeral amputation and their arm falls on the floor, that's not sakanas aver. Of course, that's sakanas nefashos. But let's say somebody has a small fracture on a finger that's clean and that's closed, it's not an open fracture, and maybe they'll lose a little bit of functionality. That will likely be sakanas aver. Number 3 is a chayla she'ein ba sakana or nafal lemishkav, which is a category of ill people who have a systemic and debilitating illness that affects their functionality, but it's not life-threatening. We'll see later, but maybe a good case would be a rheumatoid arthritis flare or sciatica. We'll see that case later. And 4 and 5 are very, very mild illnesses, which really don't have a lot of leeway in halacha. We're going to focus on Maramaka number 1, the first category, and the third category, 3, of Chodesh Ein Basakana in tonight's shir. And hopefully that's really covers, I would say, probably most of the cases that we have shailas on Hilchos Shabbos. So before we get into the halachas, as is well known, if you're posting a ribbish shaila, you better know how financing, how loans, how banking works. If you're posting a shchita shaila, you better know the ins and outs of the anatomy of animals. And of course, if you're posting any shailas in medicine, you have to know at least the basics of what qualifies as a suffix or a vada yesh bo sakana. Now, of course, to do that, you'd have to read all of Harrison's, which nobody is doing tonight. But let's go through some of the common, obvious, scenarios that would be included in a vadai or a suffix yesh bo sakana. So, of course, cardiovascular emergencies, acute coronary syndrome, a heart attack. That's always the example that Rabbanim give. The guy's having a heart attack on Shabbos. For sure, you're mechalel. So, yeah, it is true. Life-threatening arrhythmias, atrial fibrillation with RVR, a flutter, severe bradycardia, most heart blocks in SVT. Of course, decompensated heart failure, pulmonary edema, cardiogenic shock, hypertensive emergencies. Of course, if you're concerned with a dissection, a PE, cardiac tamponade. These are some of the cardiovascular emergencies that would certainly qualify for yesh bo sakana. Any neurological emergencies, of course, a stroke, whether you can concern that it's ischemic, hemorrhagic, even a TIA, which can only be ruled out, a little bit later. Any seizure or epilepsy activity, any acute altered mental status of unclear etiology. If somebody has Alzheimer's and they wax and wane, that's different. But a sudden onset, altered mental status, of course, any intracranial hemorrhage, acute head trauma, spinal cord compression, certainly would be qualified. When it comes to respiratory emergencies, these are probably the most obvious ones. Of course, shortness of breath, significant tachypnea, hypoxia, acute asthma or COPD exacerbations, pneumonia, bronchiolitis, airway obstruction, anaphylaxis. These are certainly some of the most common respiratory emergencies that would be qualified as yesh bo or suffix yesh bo sakana. Any trauma or surgical emergencies, any significant trauma. And it's important to point out, even when the mechanism alone is concerning, that's often enough to qualify somebody as a yesh bo sakana. It reminds me of a story that a good friend of mine told me. He was an early EMT, and he came to a call, and there was a child who'd fallen off a bunk bed that was approximately 6 feet tall. Definitely double the height of the child, which is usually the barometer we use for a significant trauma. And the kid was acting totally fine. They did the neurological exam as best they could in the field. Benign, nothing concerning. And the parents said, "Oh, my kid is fine. We'll just keep him home for the night, and we'll go follow it with a pediatrician tomorrow." And my friend, who was a new ENT, but he had good clinical acumen, today he's a relatively accomplished clinician, and he said, "It doesn't feel right. This was a significant mechanism of injury. It was over twice the height of the child. The kid did hit his head. I feel you should go to the hospital." Of course, no one wants to go to the hospital. He convinced the parents to go to the hospital, and the child had, I believe it was an epidural hematoma, which is a significant intracranial bleed. So you have to always use your acumen just to assess, even if somebody looks benign after a trauma, discuss the mechanism, figure out what occurred prior to the trauma, and even if initially they're benign in appearance, they could decompensate later. Okay, that's just a clinical pearl to keep in mind. Of course, abdominal emergencies, acute abdomen, bowel obstruction, appendicitis, uncontrolled hemorrhages, moderate to severe burns, many post-surgical patients. OB emergencies. It's very important clinically to always have a high index of suspicions for patients who are in the OB category, whether it's preceding, antenatal, or postnatal. It is very important to keep these patients in mind because they can decompensate much quicker than other patients. So ectopic pregnancy, severe preeclampsia, eclampsia, postpartum hemorrhage, placental obstruction, any fetal distress, etc. These are all unequivocally included in suffix or vada yesh bo sakana. We'll do a few more, and then I'm going to test everybody on them after to make sure you're paying attention. Of course, renal and hematological emergencies, acute renal failure, any electrolyte disarray, hyperkalemia, hyponatremia, hypernatremia, anuria, pyelonephritis, hypervolemia, severe anemia, any PE or DVT, moderate to severe thrombocytopenia, moderate to severe anemia. These will definitely be included in cases where you'd have a status of yesh bo sakana. Any infectious emergencies, sepsis, of course, septic shock, bacteremia, meningitis, moderate to severe infection, cellulitis, septic joint, C. diff, many abscesses, any infections in geriatric or immunocompromised patients, and of course, febrile neutropenia. When it comes to endocrine metabolic, DKA, hypoglycemia, that's significant acid base, adrenal, and thyroid storm or myxedema coma, which I did see once in the hospital. So these would also be included. And the last category before we start the halachas is oncological emergencies. And again, just from a clinical perspective, you have to be very, very, very careful and astute for these patients because they can look fine. They can have the same, strep throat, the same RSV, the same flu as anybody else. These patients are at a much higher risk for rapid clinical decline. And in almost all cases, you must treat these patients to the utmost of your capabilities. A few weeks ago, I was in the hospital on a Sunday morning, and I was rounding on a patient, and an oncology patient, and looks a little bit unwell. Vital signs were totally stable, but he had a low-grade fever, 99.5. So an oncology patient, that's concerning. We put in some orders, chest X-ray, UA, and maybe some blood cultures, and let the oncologist team know that this is what's going on. In 30 minutes, I see on my screen his fever climbed from 99.5 to 100.1 to 103.5, and his blood pressure went from normotensive to septic shock. He was in the 80s within 30 minutes, and he required pressors and, of course, fluid resuscitation. He wasn't even in SIRS criteria, meaning his infection, there wasn't even signs of anything but a low-grade temperature, and in 30 minutes, he went from this end of the spectrum to septic shock, and of course, he required ICU intervention. You have to be careful with cancer patients. They are very, very ill, and they have a high risk for decompensation. What are some of the common cases? Tumor lysis, sludging, when the white blood cell counts in leukemia go into the hundreds of thousands. We had a 300,000 one last week. That can cause all the body to stop functioning, fever, obstructive, tumor, treatment-related complications, and of course, clinical deterioration. Okay, that's definitely one or two mouthfuls. We tried to cover many, many cases of chodesh yesh bo sakana or safek yesh bo sakana. And now let's get into some of the halachas, how they pertain to these patients. So when we discuss these patients, we are discussing vadai or safek yesh bo sakana. And the question is, what are you allowed to do for these patients? What can you do and what can you not do? You definitely can be Hilchos Shabbos, we know that. But what are the parameters of what you're allowed to do? And we're going to start off with one chakira, which we're going to call a hutra or dechuya. Meaning, when it comes to Hilchos Shabbos for these patients that have life-threatening or potentially life-threatening illnesses, is it entirely permissible? You can do whatever you want. Meaning, it's like treating them as if it's Tuesday, or maybe you have to do the least intrusive approach for these patients. What we call hakal kal kaidim. You have to take the least Hilchos Shabbos to accomplish your goal for these patients. Let's see the Shulchan Aruch inside. Says the Shulchan Aruch in Shin Chav Ches, Marmaka number 5. Kishemechalan Shabbos al chodesh yesh bo sakana. When you're mechal Shabbos for a chayil who has sakana, mishtaden shloi lasos aidei enam Yehudim. We do not do it with non-Jews. We don't do it with ketanim or nashim. Rather, we do it ayidei Yisrael gedolim ubnei das. We do it specifically through shemrei Torah umitzvos. Says the Rama, no. The yesh aimrim im efshar lasos b'loi dichoy v'loi ichor aidei shinu oisa aidei shinoi. If you can do it with the shinoi in an indirect or unusual way, you do it with the shinoi. And if you can do it through ayidei eno Yehudi, you do it through an eno Yehudi. So it seems to be that the Shulchan Aruch is giving you full permission. You do it without any changes, without any shunuyim. You don't do it ayidei akum. You do it through a shemer Torah umitzvos. The Ramah seems to say, no, I disagree. You do it in the least intrusive fashion. And a classic way to explain hutra dechuya would be in a case like this. Let's say you have a patient that calls your phone. You have to go visit them on Shabbos. And you live, let's say, in Borough Park where there's a lot of traffic. So it'll take you 10 minutes to drive to the patient, or it'll take you 10 minutes to walk to the patient. Either way, you'll get there at the exact same moment. If you paskin hutra, then I could drive or I could walk. I could do whatever I want because it is like a Tuesday morning. And on Tuesday, I could drive or I could walk. So too on Shabbos, I could drive or I could walk. If you hold dechuya, then you'd have to walk because it will accomplish the exact same goal as driving. And therefore, you have to do the least invasive possible. Good. So how do we paskin? So if you look at the Taz in Marmaka number 7, Mishnah Berurah brings the Taz. The Taz says, even if I agree to the Ramah that you should do the least invasive, but practically we don't do that because we have two concerns. Let's say you only do refuah through an Ena Yehudi, through a guy. So people who see this circumstance are going to think you can only be Mechal Shabbos through a guy. Or let's say they see you doing it with the Shinoi. They're going to think you can only be Mechal Shabbos with a Shinoi. Says the Taz, what if they can't do a Shinoi? What if there's no Goyim? They're going to say, okay, I can't be Mechal Shabbos. Says the Taz, because of the concern of future scenarios, we actually do it ayedei shemer Torah u'mitzvahs, even if we paskin that it's the chuya. So it comes out halacha lamaisa from the Taz, and if you look at the Aruch HaShulchan in Maramaka number 8 and Ramesh in Maramaka number 9, they both say that we paskin like the Taz. Excuse me, it comes out that really we treat Shabbos like it's Hutra. And therefore we do whatever we need to do for this patient. We do not do it ayidei enam Yehudim, and we do not do it with a shinoi. As it says in the Kiryas Malach Rav Maramaka number 10, we also avoid a shinoi. So when it comes to the halacha lamaisa, now let's bring it all together. Of a chayla sheyesh bo sakana, or a suffix yesh bo sakana. If you're a doctor, if you're a provider, if you're an askin, if you're a patient care advocate, whatever you're going to be in categorized, if you're dealing with patients that are in these categories, you have to do the utmost to take care of them, and you must make sure that you do it in a normative fashion. So even if I could put the EKG leads on with a shinoi, or even if I have a guy standing right there who can put the IV in, that's not what halacha tells us to do. Halacha tells us we do this on our own. We do it without a shinoi, even if you have a shinoi or a guy available. The only caveat, which I say with hesitation, because I don't want it to be misconstrued, is the words of the Shlomo Zalman Auerbach and Rebbe Tzina Abba Shaul in Maramaka number 11, where they make one caveat, and they say, even though it's true that we said right now, if you're doing it for a patient who's in this category of yesh bo sakana or a suffix sakana, we do it on our own. If the Rabbanim could do it with frocks and beard, it's even better, because then everybody knows this is the right thing. But they say, if it's not directly related to patient care, for example, writing down the vital signs. So say some of the poskim, if it's not going to make any difference, and it's not going to stare at all the intervention for the patient, because it's only secondary or tertiary to patient care, you should try to use a shinoi, or you should try to use a goy. But for any direct patient care, nobody should be using shinuyim, and nobody should be using goyim to take care of patients in these categories. And if it's a non-direct patient care, then the place can recommend you should try to do it, with a shinoi or with a goy. But I'll give you a good example. There was a paramedic who spoke to me, and we were going over the halachas of, he was a new paramedic, and we were going through what to do on a call, and I maybe inappropriately was trying to, be too makbid, and I told him, if you can write down the vitals on your phone, or the story on your phone, that would be better. Fine. He tells me after Shabbos he had a call, and it ruined my entire flow. My hands were dirty, my phone was getting dirty, and this did not work out well for the patient care. So I told him, if that's the case, then you should not use your phone again to write down the vitals. You should take pen and paper, whatever is easiest for you. Meaning, when it comes to even indirect patient care, if it's going to affect the patient care, then we do not use any shinuyim. Okay, that covers really the first portion of the shir. Let's take a pause now for a minute, and we will pause for questions.
Okay, thank you so much for that. Very, very clear and a lot covered, Baruch Hashem. So first question that I think is relevant. Someone wants to know about a mental health crisis on Shabbos, thoughts of hurting oneself or others. Where would you rank that? How would you advise? And what do we do with that?
Yeah, that's no shaila. We'll cover a little bit in the next category, but anybody with past medical history of suicidal, homicidal, or thoughts of self-harm, or certainly active, that certainly would be included in a suffix, a yesh bo sakana. Yeah, I did leave that off of this list, and that was probably an omission and an error. Certainly that's included. Even patients with, let's say, bulimia, anorexia nervosa, many patients who have schizophrenia, these patients are at a high risk for decompensation. And, if they stop to lithium, they can do things that are certainly, concerning. Patients with borderline personality have a high suicide risk. So you have to be very, very, very careful with these patients. In many cases, it definitely would be included. I'd say an easy case that would be a case of, mild, depressive disorder that would not be included. Maybe that's in the next category. But yeah, anything with any of these categories will certainly be included. So if a patient runs out of lithium on Shabbos, for bipolar, go pick it up for them. Make sure they get what they need, because that could certainly cause a significant concern of real decompensation. Excellent question.
Good, thank you. Someone wants to know, where do gallstones and kidney stones fall on the abdominal list? Is that Yeshua Sakana, or are we pushing that to the next
So Okay, so it's a good question. It depends. First of all, you have to know what it is, right? Someone could have stabbing back pain, and it could be it's renal colic. It could be it's nephrolithiasis. It could be something else. Until you get imaging and at least the ultrasound or a CAT scan, it's hard to ascertain exactly what it is. So I would say for sure if it's a suffix, it could be a various other intra-abdominal retroperitoneal causes. So then I would say you definitely go to the hospital. If somebody, let's say biliary colic, let's say they have the gallbladder taken out, so they don't really have kidney stones. They get this all the time after eating certain fatty foods. They get that, biliary colic. So that biliary colic alone will cover in the neck. That's probably aimbosakana. But again, you have to be an excellent diagnostician to be able to look at a patient and rule out any cases of abdominal processes. Constipation, versus obstruction, it's the same symptomology, and without imaging, it's hard to rule it out. So if you know definitively that it's a small stone and there's no pyelonephritis, there's no fever, it's just pain, and definitively, yeah, maybe that would be aim bosakana. But you have to really make sure that your acumen and your assessment of the patient is really good to make sure there would be no sakana at all at the current time.
Good, thank you for that. Someone's asking, and again, obviously, whatever psukim they've received in the past, we had a Yom Kippur since then, but the shiloh was they were told by Hatzalah paramedics to take vitals, but mark them down with paper clips on a paper with BP numbers regarding an end of life patient. So
Well,
would you be machalik between that, or should they just
it's
in that
important.
scenario?
It's important to make note that in halacha, whether someone is a geisis or whether someone is a 1 day old baby, we do everything we can to be mechal Shabbos for them. And even if the end of life patient has dementia, they have Alzheimer's, it doesn't make a difference. We treat all nefashos and Klal Yisrael as bar kayamim, as bnei chayim, and therefore, if it's end of life, it's the beginning of life. It doesn't make a difference. Now, on that note, if taking vitals, like we said over here, Shlomo Zalman says, if you can do it without ruining patient care, and it's not going to affect your flow of taking care of them at all, so he says yishtabla, you should try to use a shinoi. In my understanding, I would think if you're trying to take vitals of a patient who's critically ill, to use paper clips is probably going to mess up the flow. I mean, all the shuls, my shul does this for the auctions, and the gabbai can barely get it straight to put the number, 36,000, like, oh, what did this guy pledge?
Amazing.
So I find it very hard to believe that, in a real call, putting paper clips will be sufficient. Let's say it's going to be an RMA patient and it was a small nick on the finger. So it's not yesh boy sakana. It's over. You just want to remember the vitals for later for the documentation. Okay, and a chanami. In that case, you're mechuyev maybe. But I find it hard in any real patient care cases to start fiddling with paper clips. I would be surprised. And I'd be Moira. I think in most cases, you should do it normally to make sure you're giving excellent high level patient care.
Got it. Thank you. And we have one more for this section.
Yep.
If there's only one person around that's Eino Yehudi and they could do the chilul, and there's no tzad that someone's going to mislearn the halacha,
Doesn't make a difference. Doesn't make a
doesn't make a
difference.
difference.
This is the halacha. The Taz says halacha psuka. The Aruch HaShulchan. Rav Moshe Feinstein, who's the Pesach Rishon, the Pesach Acharon for the Yeshaylas. We do it ayidei Yehudim. Like I said, if you had a bunch of Rosh Yeshiva and a patient collapsed, they be'etzim should all go do CPR and put the leads on. I don't know if it'd be an effective resuscitation, but in terms of Hilchos Shabbos, that would be the best approach because everyone knows this is how we treat sick people. We do it ayidei shomer Torah mitzvahs, ayidei people who are charedim, who are chasidim. You do not cheshbon each case. People are looking, people aren't looking. If it's direct patient care, this is how we treat patients. We do it on our own without any shinuyim for the direct patient care.
Yeah, and one final one. Again, this is probably going to be this section as well as the next. Someone's saying that in their area they have chaverim that will have a guy pick up antibiotics on Shabbos. Last Shabbos they had an elderly patient with CHF, exacerbation, and UTI, and the chaverim was supposed to pick it up, and they never did. So it's
Well,
spelling out the same thing I think you're saying again over and over again.
so what's the question? Again, let's speak Alib. Let's say you have a guy who's right there, and in Passaic we also have Shabbos Goyim. And it's likely that, don't forget, you have to park your car. There's a lot of shilas about the car. So it could be in that case that the guy is right there with you and the guy knows the system, and he's done this many times. So picking up the medication is not direct patient care. So in a case like that, if you have a guy who's readily available, I would be nervous in a case of acute CHF exacerbation. Even a few minutes can go between moderate fluid overload to severe. I would be very concerned. But in theory, let's say a little bit of an infection case where it's nuanced that it's pretty stable, but it's a case of a suffix sakana. So then in that case, I would say if you have a guy who's readily available with you, then in a chanami you could use a guy. But I would be hesitant to assume that would be the case in all cases. But in a chanami, if the case would be, that would be the case.
Got it. Again, I want to move things along, so I'm just going to let one more in right now, and then we'll let
Yep.
you continue. It's actually a very interesting outlook. If you have an inexperienced clinician, the mamela, a lot of the things that they're not so sure about are being moved into the Cholosh Yeshbo suffix sakana status. So, what does that person do? Let's say they're in an area that there's, you don't have every other doorway as a doctor or Hatzalah member. They're the clinician. They're a relatively new NPPA doctor. They don't necessarily feel so sure of their skills. What would the recommendation be as far as handling Hilchos Shabbos?
So that was kind of like we introduced with Rosh Zaman at the beginning, that if you don't know the case and you make a mistake and it ends up being that you totally missed the diagnosis, you're still not considered that you did anything wrong. You're doing the mitzvah of pikuach nefesh. So you didn't do anything wrong. Of course, if you're somebody that's still very, very early on, so I don't know how much anyway on your own you should be doing things. Maybe you should have somebody to discuss things over. But if you're not sure what to do, and you are qualified to treat and diagnose, then you do the most that you can for the patient. And if you're wrong, like Rav Zaman says, you didn't do anything wrong because you did the most that you could.
Thank you. And just to send this home, because I got another follow-up question on this that someone just sent. So what we're saying is that if in the matzav you're unsure, we err on the side of caution of healthcare, meaning we always treat, we always do, and you ask
Absolutely.
questions afterwards. Right now,
Absolutely.
it's not Shabbos for you. Right now, you're doing what you need to do.
Absolutely. We should
Okay.
that was the first time we started off. If you're hesitant, you delay. That's like Reb Chaim called us not apikoros. And don't forget, that case was where the doctor said, he didn't say I need the light. He said a little bit of light would be helpful. It wouldn't hurt. And yet he called us not apikoros. That's how far it goes. We don't treat, we're machmir on pikuach nefesh. It's not the pshat that we're makel on Shabbos. We're machmir on pikuach nefesh because v'chai bohem overrides Shabbos, it supersedes Shabbos. So we're machmir on pikuach nefesh. Yeah, it's excellent, excellent questions from the Olam, and I see the Olam is certainly holding in these sugyas. Okay, let's go to the next point. We'll try not to keep everybody too late. So we're going to go through some chedesh she'ein bo sakana, which is a little bit easier to go through. Let's go through some basic conditions again that would qualify, and then we'll see the halachas. So of course we said this is systemic or debilitating illnesses, but there's not life-threatening. For example, isolated pain syndromes with known etiology. I just want to make one point. If a patient has severe pain, it doesn't matter where the pain is, and you don't know the etiology, I would be very hesitant to blame it on something until ruled out otherwise. The Kadosh Baruch Hu made pain as a sign that something is wrong. Severe pain often indicates severe pathology. But let's say you know what it is. Let's say severe sciatica, a severe migraine, a tension headache that's significant, trigeminal neuralgia, muscle spasm, fibromyalgia, a flare. Let's say some GI or viral conditions that are very simple. A Crohn's disease just with cramping, obviously no obstruction. Some, let's say Epstein-Barr or, mono, where they're bedbound, biliary colic without cholecystitis, like we mentioned, they know they have, this condition. Let's say vertigo that's significant, vestibular neuritis, neuropathic pain, let's say an RA flare, rheumatoid arthritis, polymyalgia rheumatica, psoriatic arthritis flare, all these cases where there's really not any sakana. Let's say renal colic, if it's only renal colic, it's moving down the ureters, it's not obstructed, there's no pyelonephritis, there's no fever, maybe endometriosis flare, and we said psychopathic or functional issues such as moderate to severe anxiety or moderate to severe depression without any past medical history of suicidal, homicidal, or self-harm, or any current, a classic simple case of depression, but it's affecting their functionality and it's debilitating. This would be a basic overview. And the four kind of definitions are systemic, non-life threatening. The barometer could be a patient who would have to lie down to help alleviate their pain. If you're at the level where you have to lie down, that already qualifies you as this category. And the place can say, just as a caveat, let's say I have severe ear pain. Lying down is not going to help my otalgia, my ear pain. But if it would help my ear pain, I would lie down. Says the Shlomo Zalman that also qualifies, which is really the concept of a marked reduction in normal functioning, and it's clear subjective suffering without objective danger. So these are many of the cases, and there are definitely more. So what could I do and what can't I do in these cases? So what I can't do in these cases is a full-blown melacha de araisa without any shinoi. That's what I'm not allowed to do. But what am I allowed to do? And before we get to that, it's important to point out that the Poskim say, already brought in the Shulchan Aruch, that many children are qualified automatically as this category. So for all those doing pediatric, or who are involved in children, you have to realize that even if the child is in a illness or a need that's not even one of these cases, but they need it for something food or refuah related, they're automatically going to be included. And that's a Shulchan Aruch and Shin Chav Ches Yud Zayin. Mutter loimer le'eni Yehudi lases tavshir lekatan she'ein lei ma'lachal. Distam tzarchei katan kichel she'ein ba sakana. Every child is qualified automatically as an ein ba sakana. Now, what's the age? So you look at 13 to 14 to 15, there are at least three shitas. Some say 13 until bar mitzvah, which we don't really go with the halacha. Some say 9, and some say 6, some say even a little bit younger. But I would say definitely until 5 or 6, you could put children without any major suffix in this category. So the needs of children at this age are also qualified. For example, let's say a 1-year-old and you run out of formula in the house. So you could give the kid, and it's Leil Shabbos, so you have a lot more time till Shabbos is over. We have the Gerber's jars, we have the mashed carrots and the mashed peas. Yeah, I could give a kid, this for 24 hours, but it's inappropriate. We treat children as an ein bo sakana, especially when it comes to food and critical needs, and therefore you'd have a lot more heterim than just saying, forget it, I'll feed him peas and carrots for the next 24 hours. So what am I allowed to do and what am I not allowed to do? Again, for systemic or debilitating non-life-threatening, or for children under a certain age, which we'll say that's a 5 or 6 and under would almost for sure be included in this category, maybe even older in Zman HaTzeirech. So the basic principle, which is brought in 16 and 17, is you can only do a melacha dirabanan lechatchila with a shinoi. Or you could have a goy, a non-Jew, do the intervention. So again, in cases of chayla she'ein bahem sakana, what you do is either through a goy, or you do it with a shvus de shvus, with 2 de rabbanans. For example, let's say you need to call in a prescription for a chayla she'ein ba sakana. So when it comes to refuah on Shabbos, we typically treat electricity as a derabanan. So if you can call in a prescription with a shinoi, so you're doing 2 derabanans. You are pushing the phone with a shinoi, which is 1 derabanan, and you are making the electricity with a second derabanan. That's shvus de shvus. So the chazer, again, what's best to do in cases of ein bo sakana is to do 2 derabanans. Let's say that's not available to you. Then what should you do? So we have an order of operations. Again, when it comes to a chayla she'ein bo sakana, what's ideal, what's most lechatchila is to do 2 derabanans. If you don't have the option of 2 derabanans, or you don't have a guy available, so what's the best thing to do? So says the Shmir Shabbos Kelchasa in 1819 and Ravazar Maramakim 20. What's next best? She'oz mutar lasais issa derabanan. If you can do a shinoi. If you can't do a shinoi, then you use a guy. And if you can't even find a guy, you can do only even 1 derabanan without a shinoi. So let's say you have to give somebody a intervention that is only derabanan. Let's say it is mimareach. Let's say it's something of putting on an ointment or a salve for severe pain, and they're debilitated. So I could do it with a shinoi. And if I can't do it with a shinoi, so says the Rav Noivert Shmir Shabbos Kachasa, even if it's an Isser de Araisa, I could do it with a shinoi if I need. So we really have 4 order of operations. What's best is 2 derabanans. For example, using a phone with a shinoi to call in a prescription. That's best. If you can't do that, use a guy. If you can't do it with a guy, you could do 1 derabanan with a shinoi. And if that's not available, you can even do a di'araisa with a shinoi. Now, this is a little bit complicated. So, because we're all visual learners, I made an image to review these 4 categories. Again, shvus de shvus. The best is 2 derabanans. However you accomplish 2 derabanans, that's best. Second would be a mir la'akim. If you have a goy available, let's say to pick up a prescription for some gabapentin. Yeah, someone has severe neuropathic pain, no sakana, and it's hard to pick it up with shvus to shvus. So have a guy go pick up the prescription. That would be best. If you can't, you do one shvus. And if you can't even do one derabanan, then you do a shinoi on a deraisa. So let's go through one quick case just to kind of crystallize these cases because it's a lot of information in a short amount of time. Let's say you have a patient who has severe sciatica and you know they have sciatica and their treatment is typically gabapentin and lidocaine cream and they ran out of both on Shabbos. What are you and what are you not allowed to do? So let's go to the prescription first. How do you get them their medication on Shabbos? So like I said, what would probably be best would be to do 2 derabanans. So you make a phone call with a shinoi. You push the buttons with a shinoi with the back of your knuckle, and that's 1 derabanan. Electricity for refuah is also derabanan, and you call in the prescription to the pharmacy. Good. Now the pharmacy has the gabapentin. Well, how do I pick it up? I can't drive to the pharmacy to pick it up. So here, what would be best would be to do a mir la'akum. Have a guy go pick up the medication, and therefore you did shvus to shvus, 2 derabanans for calling it in, and you did a mir la'akum to pick it up. Good. Now I have the gabapentin. Of course, they could take it, no shaila. Let's say the lidocaine cream, and they have an area that has to be applied to give them good coverage. Well, if you put cream on in a regular fashion, it is the eraisa, memareach, smoothing out. You don't have a guy available to put the cream on. So what are my options? I can't even do really 1 derabanan because putting cream on is a deraisa. In this case, many places can say, if I put it on in an unusual fashion, that would also be okay, even for a non-life-threatening illness. You put on the lidocaine cream, let's say with the back of the spoon or in an unusual fashion, that would also be sufficient. So we covered calling in a prescription, which, either do shvus to shvus or a mir la'akum, and even a intervention, which is really a deoraisa, with a shinoi, if you really need it for these patients, that would also be okay. So that's a very, very brief overview of ein boy sakana. Okay, maybe we'll pause now for a few more questions on this inyan.
Okay, thank you so much. And just to go over, are we on a time schedule? I just want to know if I'm rushing or.
We'll try to finish by not too long after 10:35, 10:40.
Okay, amazing.
Not that much more to do, so we'll do a few more questions and we'll do the last 2 things are pretty quick.
Okay, amazing. So just one hara, there's a stroke NP that mentioned vertigo can be a sign of cerebellar strokes. Unless it's chronic, then it should be treated as an emergency. I just wanted to put that out.
Yeah, excellent. It has to be that's it. You have to know, like I said, you have to know that a patient has these pre-existing conditions that, a new onset 80-year-old with vertigo, hatzlacha rabba. Yeah, good luck calling that in the field. Of course they're going to the hospital. It has to be that you know the etiology of their symptomology. I'll give you one other case. Sometimes we have patients who have new onset back pain. Oh, it's a slip disc. It's a slip disc. Well, yesterday you were walking, and today you can barely move. We had a case a few years ago where it was millimeters from full spinal cord compression. So again, wow. Very. One of the other shurim I gave, they actually took a picture of the disc of how far it was and how large it was. So of course that's a suffix. It has to be where definitively it's just pain. And you know the etiology. That's very, very critical to emphasize. So whoever made that ha'ara, it's an excellent ha'ara. Yes, dizziness can also be a sign of a stroke. If you know that you get, vertigo, so enochanami, to pick up meclizine is different, but an older patient, 100%.
Okay, we have a nephrology question for you. How long after kidney donation are they considered yeshua sakana?
Good. So this is a question that you have to ask the transplant nephrologist. Why? Because every transplant nephrologist gives a different geder. Some say 2 months, some say 3 months, some say 6 months. So I tell you to ask your transplant nephrologist what they feel is the appropriate time. There is a book, I think it's called Kidney Donation in Halacha. You can imagine what it speaks about. And there they bring different shitas. But in my opinion, people ask me this. I tell them, ask your transplant nephrologist what their opinion is.
And they're asking first Shabbos after. Is that a double pasha? They could turn on a heating pad, do whatever they need to do?
Again, you have to ask their nephrologist at to what point are they considered yesh bo sakana. Once they're considered yesh bo sakana, then enochanami. We treat them as a yesh bo sakana. So the same way for somebody who's having a heart attack and they need a change in the heating of the room because they're very uncomfortable. So if you're still a yesh bo sakana, then yesh bo sakana. You don't have to hesitate to do things. But again, you should ask. Every team has different opinions of what the exact zman is.
Got it. Someone wants to know, what does a gout flare-up fall under, assuming they're confident there's no concern for septic arthritis. It's just a
Good.
painful component.
Yeah, so I think we had gout on the previous one. That's you have a classic person who has podagra, which is gout in the big toe. They get gout flares all the time. It's not a septic joint. It's not, severe cellulitis. It's not an abscess. They get this all the time. You know 100% what it is. If you were in the clinic, you give them colchicine and you would tell them, indomethacin and call it a day. So, excuse me, on Shabbos, it would be the same exact thing. This is ain basakana. It's severe pain. Podagra is exquisite pain. Never had it before, but that's what the patients say. So in a harami, that's like the gabapentin. If they don't have colchicine, they don't have indomethacin. So call it in with the shinoi and have a guy go pick it up for sure.
Got it. Someone wants to know, if a child has a tick on them on Shabbos, let's say they're under 6 years old, can they take it off? Can they use a tweezer, etc.? How are we
Yeah,
rating
I
that?
mean, for sure, it's a good question. I would really say, and don't misquote me on this, but we know that tick-borne illnesses are very significant. Lyme disease can cause significant ehrlichiosis, babiosis. There's many, many, many conditions that can occur out of a tick. So I would say at a minimum. Well, I'm gonna tell you this: you have to get the tick out. I'm not gonna tell you how you define this person. Get the tick out. If you can't get it out on your own and you don't know how to do it, find a way to get the tick out. You definitely don't leave a tick in, because we know the longer it's in, the more likely the likelihood for tick-borne.
Lyme. Yeah.
Yeah, Lyme is it's not only Lyme. Today we know there's, I said, ehrlichiosis, babiosis, there's many other things that I'm familiar with. You have to ask the ID people. But we don't mess with Lyme disease. We don't mess with tick-borne illnesses. So get it out. If you can't get it out with any of the, if you have to get it out. I'll tell you like that. Figure out how you get it out, but it must be taken out as soon as possible. Do not mess around with the tick.
Got it. Do we consider a loss of a tooth a sakana saver?
So we're not really getting into sakanas aver, but the Paiskim say the loss of one tooth, it's brought in Shulchan Aruch, is not considered a sakanas aver. But again, if you have a traumatic injury to a tooth and you have bleeding issues, you have infection issues, you need intervention in the mouth. So and it's a different category. But objectively, the loss of just a tooth would not be considered sakanas aver. What it would be qualified as, it's not exactly clear. It's pretty not so severe in the eyes of halacha. Maybe you have a guy put it into milk. Maybe you could have a guy drive you, but it's definitely not sakanas aver. That for sure it's not.
Okay, we got a Inyana Dioma question, definitely out here in the five towns, Mustoma, New Jersey as well by you. Flu, both
Oh,
the testing as well as Tamiflu is a prescription. How are we ranking that on Shabbos?
so it's a good question. The flu definitely has the potential, for unfortunate significant decline. If it, in terms of testing, so I would say, let's say somebody comes in, they're okay in appearance, but they have some mild, myalgias and maybe a little bit of a runny nose. So in terms of point of care testing, we really, so it's definitely, in my opinion, at least she'ein basakana, if you're suspected that there's a systemic infection, and they're definitely feeling the infection. So we do point of care testing, which is really going to be, at the most, it's only going to be one derabanan. So just to go through the steps, if you do the tests at home, you open up the wrapper, try to avoid taking the letters out. The little cassette, with the dropper. So maybe there might be schita de eraisa when you put after you swab the patient and you put it into the tube. So maybe try to squeeze the Q-tip fluid into the fluid in the container with the shinoi. You should try. And when you drop it in, also try to do it with the shinoi. But you definitely should get the testing done. So in cases like this, if it's a healthy person, and it seems to be just a mild early onset case, I don't know if there's a reason to do those types of interventions normally. But if you need somebody, let's say a little bit more progressive, a little more significant, they have some chest pain, they have some pleurisy, they have some concern for real pneumonia, they're a bit older, they're immunocompromised, and maybe they're very young, I would say that's probably pushing closer to a yesh sakana. Again, for the testing, which maybe isn't direct patient care anyway, you should do it in a more lenient fashion. But to get somebody Tamiflu or Zofluza, I would say, again, you have to get it for them on Shabbos. What would be best with two derabanans, a guy, maybe a shina on a deraisa. And if ultimately somebody, seems to be even beyond the basic viral syndrome etiology, and you cannot get them the, medication any other way, I could hear a good side, go get it yourself. If they're showing, signs of even, I would say, mild to moderate, right at the early moderate, I'll definitely say they should go. You can even get it yourself, but probably, use the more lenient fashions first.
Got it. Thank you. We actually have a lot of really good questions, so I'm going to try to get through everything.
Okay.
We have an L&D nurse asking, let's say a preemie, the mother has some milk in reserve. Is she allowed to pump milk on Shabbos and save it for the preemie, even though she has reserves?
even if she has reserves and she knows
Meaning
she's
they could
best.
get through a couple of daings, but as we know, every last little bit counts, etc.
Yeah, I mean, there's a few ways to think for a second in that case. If you have a concern, you're going to need the milk. I mean, usually they say to keep the
The
pump on,
colostrum.
yeah, yeah, colostrum for sure on a timer. That'd be the best way. To use the pump. That'd be best, or turn it on with the shinoi. If you need to turn it on with the shinoi, and then you could pump. That would be okay as well.
Okay, so we're making a durabundant effectively, meaning we're saying
Yeah,
ideally not to go strip, but if the baby needs it, then there's nothing
yeah,
to talk
maybe
about.
not forget it, but a few days later, and you'll have enough. Again, in cases like that, like it's also not direct patient care. You're not doing it right now, so why not turn the pump on with the shinoi, right?
Yeah,
You're probably at two derabbanans, doing it that way. If you do it with just turning it on direct, it's one derabbanan. And if it have to be over a real deraisa, so I'd say try to do it with the shinoi in that case, where it's not mamash in front of you, and you might not even need it. That's probably closer to the category of even if it's yesh plus sakana, we try to do it indirectly with things that are not directly involved in patient care.
got it. A child with a child or adult with a fracture, but they have good circulation. Is that are we dealing with that on Shabbos or waiting till Motzei?
I think you have to have a very good clinical acumen to determine that there's no neurovascular compromise. It's not a significant fracture. Things can progress pretty quickly. I'd say maybe a finger, closed fracture on a distant, phalange or distant, maybe you could wait. Maybe again, you could always have a guy, take you to the hospital. We said Amir La'akim is fine. If you don't want to do it that way, I don't know, any significant forearm or upper arm or definitely large bone, I would say that's probably suffix sakana. Until you get imaging, it's hard to know the extent of the fracture. So I would say in those cases, it's probably nechshav suffix yeshba sakana until proven otherwise.
I would pipe in as well. I recently saw an orthopedic surgeon in Shul see an arm that was already treated for a couple of weeks, but he was mistook compartment syndrome, or maybe the circulation. He sent them in a hot cell on the
Yeah,
spot. He
yeah,
didn't even
that's
think
no
twice.
shaila. I mean, compartment syndrome is real sakana. Neurovascular compromise, ischemia, gangrene, especially a few weeks old, and there's still issues. Yeah, I mean, it could be there's infection. There's lots of things that could be going on. I definitely would not mess with any cases like that. But a simple, deformity, you can kind of see it on on the hand. But I would still push those cases. Definitely, those patients should go to the hospital on Shabbos. And if they go with a yid, I don't think that would be really any issue with that as well.
Got it. Okay, a young child, let's say 3 to 6 years old, parents bringing the kid in for strep or checking ears Shabbos morning. Is this something that you'd be macha, you push them off till Motzei Shabbos, or if the
No,
kid's in tsar, you deal with it on the spot?
even if the kid's not in Sarah Baisai, if it's a child and they have an illness, anything related to their care is automatically at least in Baisakana. So why would you wait until Motzei Shabbos? Right now, you're mechuyev to take care of them. Do the exam, do the strep test. If they need amoxicillin, so call it in. Like we said, call it in with a shvus, and you're covered. Have a guy go pick it up. Fine. If you can't have a guy go pick it up, you go in an Uber yourself and go get it. But I definitely would not wait till Motzei Shabbos in cases like that. It's at least ein basakana at a minimum.
And just to be clear, we're turning on the light, otoscope, etc. We're turning on with the Shinoik. It's a LED anyways. It's not.
Yeah, it's LED, right? It's probably anyway derabanan. So turning on the light with the shinoi, that often with the otoscope, that's what when this comes up, that's what I'll typically recommend, especially if it's an ein basakana. You definitely have two shvusim. Checking it, you don't have any issues, and like we said, that the swabs, most of the rapid point of care testing can be done in a multiplicative fashion without any affecting patient care. So yes, I would not wait. We don't wait on infections, Rabbi Say. We treat infections in front of us. Many times it's even suffix sakana, but even an early onset strep throat in an 11-year-old, which is unlikely to qualify as sakana, even though some say it is, for sure treat it on Shabbos. Please do not wait till Motzei Shabbos.
Thank you for that. And one, this is actually a little bit of a lumdish. Someone wants to know if the new derech of doing something is with the Shinoi, does that become the new norm? Does the Shinoi ever become the norm
Yes,
that with Pichosh is bed?
it's a very good question. They say, I think that in surgical residency, they make the surgical residents eat, let's say they're righties, they have to eat and do everything with their left hand because they want them to become ambidextrous. So, in so to this is what if you always do it with the shinoi, there are poskim that say that it's no longer qualified as a shinoi. So, okay, whether we pass them like that, that's, we can speak about that later in person, but I think you could always have many ways to do shinuyim, in which case, you have to be a very, very creative person to run out of shinuyim. But enechami, it's an excellent question, which it is a machlokes paiskim. I'm not going to give a definitive psak right now.
Okay, one final question on this before I let you go to the next part. Legabe the otoscope, should they leave it on and not turn it off? when they're
No,
done using it? Oh, because they might have
no.
to use it for the next.
Yeah, I would turn it off with the shinoi, which is also maybe even three derabanans, right? It's electricity, it's a shinoi, and you have kiboy, which is malach chen shricha lagufa. No, you might need it again. The same with a nebulizer. Patients ask, let's say a patient, is nebulizing for a very simple case that's not even yesh leave it on the whole Shabbos. No, you might need it again. You don't leave this on the whole Shabbos. It's going to break the machine, and therefore, if you're going to need it, it's likely you might need it again. You turn it off with the shinoi. Yes, if it's 5 minutes before Shabbos is over. So in that case, I don't think it's wrong to not turn it off. But if it's Leil Shabbos, Shabbos morning, and you might need it, I certainly would not leave it on the whole Shabbos or any other device that you might use. Your monitor, your EKG machine, whatever other thing that might be battery powered or might malfunction by leaving it on. I certainly would not leave it on the whole Shabbos.
Yeah, and one more for this section. What about reducing a nursemaid's elbow on Shabbos? Are we leaving that or taking care of it ASAP?
No, especially for children, like we said, it's aim sakana, and nursemaid's elbows is not going to be considered deraisa. It's not really a broken bone. The place can speak about this. So if it's going to be a case of a child for sure, which most cases nursemaid's elbow is, then you should reduce it. Again, I don't know if you could really reduce it with the shinoi. That'd be challenging. So you could reduce it in a normal fashion. But also make sure okay, fine. Most people know it's nursemaid's elbow. Once in a while, there was a story once that one of my children, the doctor thought it was nursemaid's elbow and tried to reduce it and heard a crunch, and it was a
Oof.
yeah fracture.
That's
Yeah, you know it was a small fracture. So okay, don't always assume nursemaid's elbow. Make sure you have good clinical acumen to know what it is. But yeah, many times it's easy mechanism. You know what it is. So yeah, I would reduce that on Shabbos for these children if you could. You maybe do it a little bit unusually, okay, but otherwise do it in the way that you need.
okay. And one final, sorry, just came up. I don't understand necessarily. Maybe I'm missing something. Is there a reason to get a special LED light for autoscope? Do they even make incandescent bulbs on autoscopes anymore? They're all LED at this point, no?
So I'm not dating myself. I'm not that old, but I think mine is still an incandescent.
Okay, so that's a good shout.
Yeah, is it better? It's definitely better. Again, if you're buying one anyway, it's not a big deal. L'chatchila, so why would you not buy one? It helps you for the eimbas hakanas, right? You're mitigating your entire severity to at the most being one derabanan. So you're in a much safer category. Of course, if it's a yesh sakana, you could use a torch, if you need with fire to look at them. But objectively, yes, if you could set it up for cases where it's going to be of ein basakana, which many times the otoscope is. So yeah, why not get one with an LED? That will limit the severity of your Isra Malacha.
Got it. Okay, there's some more, but I want you to
Yeah.
get to the next part.
Let's
Some
do
more or
let's do
less.
let's do two more quick things, Rabbi. So we'll end officially in about 5 minutes. It's two pretty quick things, just because people email me. This has sutures on Shabbos. This is like the biggest shaila in the Paiskim. What do you do? What don't you do? So I'm not going to give a definitive psak for every case because it's a major machlekes in the Paiskim. But let's just give some basic recommendations when it comes to suturing on Shabbos. The first thing I would say, which every single good plastic surgeon will tell you, is you have to clean, clean, and clean every single wound. As we know, dilution is the solution to pollution. It is very important to clean every single wound that comes in front of you before you even think about the halacha. And you also have to look and probe before you think about what the halacha would be. People text me, even on a weekday, does this need stitches? It's a picture of a cut. I don't know. I don't know how deep it is. I don't know what the edges are. You can't tell from one picture whether it does or doesn't need sutures. So first, just do the appropriate assessment. Now, the shaila in Regel Achas is a shaila of taifer, of bringing the body closer together, which is sewing, and kaisher, tying the knots of the sutures. And there's shitas in the achronim. Is it deraisa? Is it derabanan? Maybe it's motu legamre. So I'm not getting into that shaila definitively. But let's give some rules that we could give definitively. First of all, if the wound is deep, it's dirty, it's at risk for additional contamination, there's a concern of poor hemostasis, there's an infection risk, it's the back of the hand or the back of the foot, the injury was with a metal object, it's a dirty object, it's small children, they're immunocompromised, diabetics, poor vascularity, many geriatrics, sensitive areas where they're dirty, v'chule. These are all cases of suffix sakana. So there's no shaila, you can suture in these cases. And the Paiskim say, even if you need to do a few extra sutures for cosmetics, if be'ikr, it's a yesh by sakana, you can do whatever you need. So that covers a lot of cases. Now, let's say it's a repair solely for cosmesis. It's only for cosmetic purposes. So I think it would be best to send them to a goyish plastic surgeon if you have them available, because that will avoid a lot of the shilas. An example would be, let's say, a small single layered, laceration on the forehead. And if you don't want to send it to a guy, so what you can do, and this is recommended from a very excellent clinician, you can take some steri strips that are pre-cut with iodine, which have some antimicrobial or bacteriostatic properties, close it up, and a few hours later, they can take care of it. There's a big shayla of exactly how long the time is. Is it 6 hours? Is it 8 hours? Is it 12? I put some data on the bottom. You can take a look. But I would say in one end of the spectrum, if it's a suffix sakana, which is many cases, take care of it normally. If it's super cosmetic, super superficial, so what's best is probably to send it to a guy for plastics, ideally, or you can just put some steri strips that are already pre-cut and wait till after Shabbos. Even in cases of cosmetics, there are some leniencies, real tzarchim. So I would just be ma'arer. Some ways to make it more lenient is to use absorbable sutures, fast absorbing gut, and staples and dermabond are also more appropriate. I'm not saying you have to use these, but these are definitely going to be more preferable. So we're not going to cover every case, but you cover lots of cases for sutures. So that's just one aspect. And one more thing, the last Indian people asked about billing on Shabbos. Can you bill for things that you did on Shabbos? The short answer is yes. Obviously, don't fill out your chart on Shabbos if you don't have to. But on Motzei Shabbos, you put it into EMR, it's going to bill. The reason why it's mutter is, first of all, it's the tzarech mitzvah, and likely the insurance pays you in bundled payments, so it comes b'havla'ah. Often you call a patient for a follow-up, or there is a follow-up. So if you have one of those two capacities, it's also going to be included in the heter because it's b'havla'ah. Some say all the studying that you did to become a provider also is included in the havla'ah because it was done before Shabbos. And lastly, for many people, if they won't get paid, they might not do it again. So in short, when it comes to getting paid on Shabbos, yes, you can get paid for your procedures and interventions on Shabbos, and there's no issue of schar Shabbos. You don't even have the inyan of ein boy simin. Bracha kach kabalti mekama paiskeg da hadar. Okay, I thank you all for coming. I'm happy to stay on for a few more minutes for a few more questions, but this covers yesh basakana, ein basakana, children, suturing, and getting paid on Shabbos. This is a small dent in the big sugya of refuah on Shabbos. Thank you all for coming. And I hope that everyone got something out of tonight's shir.
So thank you so much for that. Very, very clear. We will be sharing Rich from the PDF on the chat as well as a recording of the share. Just to go over a couple more questions that came up. Is there a tzad that Hatzalah members should prefer to get an electric car? Is that helping him be Mamayit Yisurim?
Yes, it's a very good question. If they're buying a car anyway, and they're happy to get a Tesla, so yeah, it is Mamayit to Israel. They're not mechuyev to go buy a Tesla, especially because all the credits expire now. But yeah, it definitely is less malacha. Again, whenever Hatzalah is called, whenever we're driving, we're always going as a suffix yesh basakana. You can't drive to a call if you know definitively it's an ein basakana. With an electric car, you actually, would be able to because that's a derabanan. So again, it may help you in some cases, but definitely not mechuyev to go buy an electric car. But in theory, it does avoid some of the shilas of turning the car on, turning the car off, parking. So yeah, if it works for you, go for it.
Okay, thank you. Let's say a provider that's not typically on call on Shabbos, he's not a Hatzalah member, but he invariably will have a few missed calls sporadically on different Shabbosim. Does he have an achrayus to carry a phone on Shabbos?
If he's dealing with, let's make it easy. If he's dealing with, yeah, let's keep it broad actually. Yeah, is he mechuyev to keep it on him or?
Meaning he's not let's say a family medicine. Let's say he's a specialist or he's a neighborhood guy that people know is knowledgeable. He's not on Hatzalah. It's not his achrayus, but he'll get a couple calls. People will call him for things.
If people are calling him with some regularity on Shabbos, then I would say that's considered. And the cases are real cases. It's not somebody who's doing something that's not related to any sakana at all. Let's say he's a hematologist, yeah, or an orthopedist. These are cases, or even a dermatologist with deep cuts. Yeah, I mean, I would say a person like that has the heter to keep it on him. Now, if he's walking the shul without an erev, so he should walk with it with a shinoi, putting it in his hat, putting it in his sock. If he answers the phone, he should answer it probably with a shinoi if he could. Well, he doesn't have to, but he could because he's dealing with cases of safek pikuach nefesh. I'm sorry, I'm going to correct that line. If he's answering the phone from a front person, he should answer without a shinoi because he knows it has a category of safek pikuach nefesh. But carry it on him, with a shinoi and rabim because I would say that would probably be appropriate in this case.
Got it. Is there any reason for Hatzalah organization to change EMS protocols regarding dispatch due to Shabbos, meaning let's say they would send to this type of emergency 2 cars on Shabbos, they diminish, or is Shabbos Tuesday for all their concerns?
It's not Tuesday. That people say that sprach. When you're dealing with patients and you're dealing with the call itself, it's Tuesday. But when it has to do with other cheshbonis, so I'm not exactly sure what the question means. If you should change protocols,
Their
can you
question
comment
was,
a
let's
little bit
say
more?
2 units normally go out for respiratory distress. So on Shabbos, is it 2 units as well, or they should be might?
No, absolutely. Respiratory distress is suffix yesh zakana. Absolutely. Once in a while, what we'll do here is if the dispatcher is also an EMT and they're very knowledgeable and they hear like it sounds like it's something that's very, very, very minimal, it's still a suffix. Maybe they'll say one member should go check it out. The same way during the week, that's what they would do, right? Here locally, at least, we'll send one member to go check it out if they're not sure. Now, you never really know, but in cases where it's extremely likely, it's a very small finger laceration. So in Echanami, what you do during the week, Rav Shlomo Zalman says, in Echanami, you should replicate what you do during the week as you do on Shabbos for cases like that. But definitely start to change protocols in general would be entirely inappropriate.
Got it. Okay, I don't know if you wanted to save Ava for another share, but someone wanted to know if they show up to Eno Yehudi's house, is there
Do
any
every
chiluk?
single thing that you need to do to save this person's life. Do it. No shaila. If you're driving to the hospital as a guy who could drive you, fine. We get calls once in a while in Passaic on job, especially with the paramedics. So they go to the call, they treat the patient as best they can to give excellent patient care. If our 90s, which are our goyim, are on scene, so even though typically we drive to the hospital, but if it's a case like that, if a guy is there, let the guy drive to the hospital. But you do not make any shinuyim in treating these patients. It is a very, very chomer shaila, and please do not make a mistake of limiting or decreasing or modifying direct patient care. In a case of Ava, it's a very chomer shaila, and please do not make mistakes in that aspect.
Got it. And again, I don't know if the Rav fully covered this, but when is a laceration considered a sakana? I mean, that's like a
Like I said,
very
you can't know every single case, but like I said, if it's a dirty wound, if it's deep, if it's a geriatric in many cases, immunosuppression, diabetics, dirty, a metal object, the back of the hand, those are all cases that would qualify as suffix or yesh sakana. Like I said, a small clean laceration on the forehead, child bumped into a wooden post in their house, Shabbos is over in a few hours. It's hard to call. That definitely would not be considered. It's not deep, definitely would not be qualified as yesh sakana. Therefore, it would be only cosmetic, and therefore, what you can do is definitely limited because it's potentially shayach that suturing is at least a tzad that is a deraisa. It definitely could be a suffix deraisa.
got it. Okay, we're done for tonight.
Okay, shkar chabayis be matzliach. Thank you for coming, and we're looking forward to many more of these together.
Thank you. Have a wonderful night, everybody. We look forward to future shiurim, and please reach out regarding sponsorships. Like I said before, they're very helpful in keeping this going. And please feel free to email as well if you have any specific concepts or topics you want us to cover. Have a wonderful night.